Hi, I am Dr. Michelle Shiller, a pathologist at Baylor Scott & White Health. I'll be discussing folate receptor-alpha, or FR-alpha, in ovarian cancer. FR-alpha is a glycoprotein receptor expressed on the cell surface that binds to and transports folate into the cell. It can be highly expressed in ovarian tumor cells and has limited expression in normal cells, which makes it a relevant biomarker in ovarian cancer. In fact, FR-alpha is expressed in the tumors of 90% of patients with ovarian cancer. Approximately 35% of patients with advanced ovarian cancer have tumors that are considered FR-alpha positive, which means that greater than or equal to 75% of viable tumor cells are staining at greater than or equal to 2+ intensity. Knowing this information about a patient is important, especially for patients with platinum-resistant ovarian cancer, or PROC, who are challenging to treat and have limited therapeutic options. FR-alpha testing is recommended by NCCN Clinical Practice Guidelines in Oncology for ovarian cancer, including fallopian tube cancer and primary peritoneal cancer. They recommend tumor molecular analysis, including testing for FR-alpha for patients with recurrent disease, if not done prior, to identify potential benefits from targeted therapies. Next, we'll talk more about specific details regarding FR-alpha testing. Testing can be performed on archival or recently acquired tissue. Since ovarian tumors are heterogeneous, retesting can be considered based on your clinical judgment if other tissue is available or more recent tissue is acquired. A majority of patients with ovarian cancer will become platinum-resistant at some point, meaning progression-free interval less than or equal to 6 months. So knowing these test results can help doctors plan in advance for which therapies they may be eligible for in the future. Testing for FR-alpha is done on formalin-fixed, paraffin-embedded, archival, or recently acquired tissue using the Ventana FOLR1 IHC assay. Since FR-alpha is a protein, expression is determined via IHC, so genomic testing, either by tissue or liquid biopsy, cannot be used. Performing FOLR1 testing is similar to other standard IHC assays and can be done in a central lab or in-house. Some labs now include the Ventana FOLR1 assay in their ovarian cancer panels, but it may not be performed automatically. Since FOLR1 is an IHC test for a protein, double-check that it is included with a broad NGS gene panel, and if it's not, it should be ordered separately as a standalone IHC. The process and turnaround time should be confirmed with the lab. For pathologists, it's important to report the staining intensity percentage to make the findings really clear. Additionally, it's important to note that when requesting a full panel, doctors may be relying on pathologists to ensure that all the relevant tests are being ordered. This is why it's important to proactively ensure that IHC testing for FR-alpha is included for patients with ovarian cancer. Now, if you find that the patient's tumor is FR-alpha positive, with 75% or more of viable tumor cells staining at greater than or equal to 2+ intensity, a targeted treatment called ELAHERE may be right for them. We can also include this recommendation for a treatment option in the report for appropriate patients. ELAHERE is an FR-alpha targeted antibody-drug conjugate, or ADC, that is indicated for the treatment of adult patients with folate receptor-alpha positive, platinum-resistant epithelial ovarian cancer, fallopian tube cancer, or primary peritoneal cancer who have received 1 to 3 prior lines of therapy. Patients are selected for therapy based on an FDA-approved test. You should know that there is a boxed warning for ocular toxicity. ELAHERE can cause severe ocular toxicities, including visual impairment, keratopathy, dry eye, photophobia, eye pain, and uveitis. Patients need an ophthalmic exam, including a visual acuity and slit lamp exam, prior to starting ELAHERE, and then every other cycle for the first 8 cycles and is clinically indicated. They should also use prophylactic artificial tears and ophthalmic topical steroids. If there are ocular toxicities, ELAHERE should be withheld until they improve, and then you can resume at the same dose or consider a reduction. If any grade 4 ocular toxicities occur, you should discontinue ELAHERE. So in closing, approximately 35% of tumors in advanced ovarian cancer are FR-alpha positive, which means that greater than or equal to 75% of viable tumor cells are staining at greater than or equal to 2+ intensity. Remember that testing for FR-alpha expression can be done on FFPE tissue collected at any time, including as early as diagnosis, at debulking, or after chemotherapy. Testing for FR-alpha via IHC is a required step in order to determine a patient's eligibility for targeted therapy with ELAHERE, the first and only FDA-approved ADC targeting FR-alpha. Contact your ELAHERE representative for more details about FR-alpha testing and treatment with ELAHERE. If you don't know your rep, you can contact one at the website.
Indication and important safety information. Indication. ELAHERE is indicated for the treatment of adult patients with folate receptor alpha positive, platinum-resistant epithelial ovarian, fallopian tube, or primary peritoneal cancer who have received 1 to 3 prior systemic treatment regimens. Select patients for therapy based on an FDA-approved test. Important safety information. Warning: ocular toxicity. ELAHERE can cause severe ocular toxicities including visual impairment, keratopathy, dry eye, photophobia, eye pain, and uveitis. Conduct an ophthalmic exam, including visual acuity and slit lamp exam prior to initiation of ELAHERE, every other cycle for the first 8 cycles, and as clinically indicated. Administer prophylactic artificial tears and ophthalmic topical steroids. Withhold ELAHERE for ocular toxicities until improvement and resume at the same or reduced dose. Discontinue ELAHERE for grade 4 ocular toxicities. Warnings and precautions. Ocular disorders. ELAHERE can cause severe ocular adverse reactions, including visual impairment, keratopathy, corneal disorders, dry eye, photophobia, eye pain, and uveitis. Ocular adverse reactions occurred in 59% of patients with ovarian cancer treated with ELAHERE. 11% of patients experienced grade 3 ocular adverse reactions, including blurred vision, keratopathy, corneal disorders, dry eye, cataract, photophobia, and eye pain. 2 patients, 0.3%, experienced grade 4 events, keratopathy and cataract. The most common greater than or equal to 5% ocular adverse reactions were blurred vision, 48%, keratopathy, 36%, dry eye, 27%, cataract, 16%, photophobia, 14%, and eye pain, 10%. The median time to onset for first ocular adverse reaction was 5.1 weeks, range 0.1 to 68.6. Of the patients who experienced ocular events, 53% had complete resolution, 38% had partial improvement defined as a decrease in severity by 1 or more grades from the worst grade at last follow-up. Ocular adverse reactions led to permanent discontinuation of ELAHERE in 1% of patients. Pre-medication and use of lubricating and ophthalmic topical steroid eye drops during treatment with ELAHERE are recommended. Advise patients to avoid use of contact lenses during treatment with ELAHERE unless directed by a healthcare provider. Refer patients to an eye care professional for an ophthalmic exam, including visual acuity and slit lamp exam, prior to treatment initiation, every other cycle for the first 8 cycles, and as clinically indicated. Promptly refer patients to an eye care professional for any new or worsening ocular signs and symptoms. Monitor for ocular toxicity and withhold, reduce, or permanently discontinue ELAHERE based on severity and persistence of ocular adverse reactions. Pneumonitis. Severe, life-threatening, or fatal interstitial lung disease, ILD, including pneumonitis, can occur in patients treated with ELAHERE. Pneumonitis occurred in 10% of patients treated with ELAHERE, including 1% with grade 3 events and 1 patient, 0.1%, with a grade 4 event. 1 patient, 0.1%, died due to respiratory failure in the setting of pneumonitis and lung metastases. 1 patient, 0.1%, died due to respiratory failure of unknown etiology. Pneumonitis led to permanent discontinuation of ELAHERE in 3% of patients. Monitor patients for pulmonary signs and symptoms of pneumonitis, which may include hypoxia, cough, dyspnea, or interstitial infiltrates on radiologic exams. Infectious, neoplastic, and other causes for such symptoms should be excluded through appropriate investigations. Withhold ELAHERE for patients who develop persistent or recurrent grade 2 pneumonitis until symptoms resolve to less than or equal to grade 1 and consider dose reduction. Permanently discontinue ELAHERE in all patients with grade 3 or 4 pneumonitis. Patients who are asymptomatic may continue dosing of ELAHERE with close monitoring. Peripheral neuropathy. Peripheral neuropathy occurred in 36% of patients with ovarian cancer treated with ELAHERE across clinical trials. 3% of patients experienced grade 3 peripheral neuropathy. Peripheral neuropathy adverse reactions included peripheral neuropathy, 20%, peripheral sensory neuropathy, 9%, paresthesia, 6%, neurotoxicity, 3%, hypoesthesia, 1%, peripheral motor neuropathy, 0.9%, polyneuropathy, 0.3%, and peripheral sensory motor neuropathy, 0.1%. Monitor patients for signs and symptoms of neuropathy such as paresthesia, tingling or a burning sensation, neuropathic pain, muscle weakness, or dysesthesia. For patients experiencing new or worsening peripheral neuropathy, withhold dosage, dose reduce, or permanently discontinue ELAHERE based on the severity of peripheral neuropathy. Embryo-fetal toxicity. Based on its mechanism of action, ELAHERE can cause embryo-fetal harm when administered to a pregnant woman because it contains a genotoxic compound, DM4, and affects actively dividing cells. Advise pregnant women of the potential risk to a fetus. Advise females of reproductive potential to use effective contraception during treatment with ELAHERE and for 7 months after the last dose. Adverse reactions. The most common, greater than or equal to 20% adverse reactions, including lab abnormalities, were increased aspartate aminotransferase, fatigue, increased alanine aminotransferase, blurred vision, nausea, increased alkaline phosphatase, diarrhea, abdominal pain, keratopathy, peripheral neuropathy, musculoskeletal pain, decreased lymphocytes, decreased platelets, decreased magnesium, decreased hemoglobin, dry eye, constipation, decreased leukocytes, vomiting, decreased albumin, decreased appetite, and decreased neutrophils. Drug interactions. DM4 is a CYP3A4 substrate. Closely monitor patients for adverse reactions with ELAHERE when used concomitantly with strong CYP3A4 inhibitors. Use in special populations. Lactation. Advise women not to breastfeed during treatment with ELAHERE and for 1 month after the last dose. Hepatic impairment. Avoid use of ELAHERE in patients with moderate or severe hepatic impairment, total bilirubin greater than 1.5 upper limit of normal. Please see full prescribing information, including boxed warning, at ELAHEREHCP.com.